Hello, good evening everyone. Saloni, am I audible?
Yes, you are.
Okay. Very good evening to one and all present here, and I will welcome all the candidates who have shown their interest in attending the demo lecture for public health dentistry for Masterclass 1.0. Right, and now on this Masterclass demo, we have Dr. Rangoli Srivastava, who is our faculty for public health dentistry. So I welcome Dr. Rangoli Srivastava on this platform. We are happy that you have joined us on this venture.
Thank you. Thank you, Drumil.
Yes.
And a very good evening to all of you. And it's really nice to see your everyone's keen interest in this particular demo lecture. So, shall I begin my today's lecture?
Yeah,
Am I
yeah.
audible and is the screen visible?
Yeah, your screen is properly visible and your voice is clear. Just
Okay.
I'll give a basic introduction so that students know who you are
Yes,
and what
yes,
you do,
sure.
and then you can resume with your class, right? So,
Sure.
Dr. Rangoli Srivastav is right now currently a postgraduate third year from public health dentistry. She has completed her UG from Maharana Pratap Dental College, and right now she is pursuing her postgraduate from Tirthankar Mahavir University, Moradabad, right? So she will be
Yes.
dealing with this subject for the next 2.5 months for those candidates who are interested in joining the Masterclass 1.0. And without wasting much of time, I'll hand over the platform to Dr. Rangoli so that she can start with her lecture. Okay?
Sure.
Okay. Yeah.
So, before I begin my lecture, can I have everyone's attention and can you please just let me know that you are here with a thumbs up or any sign? All the final years that are into learning the subject. Great. I am receiving some responses. So, let me begin with today's particular lecture. I have particularly chosen one very important topic. It's a topic which is important not only from public health dentistry point of view, but is also of relevance in pediatric dentistry also. And this particular topic is very important for your short notes. Along with that, it has a probability of coming in the long notes too. So let me begin with today's topic. It's a traumatic restorative treatment. You all must have heard about it and you all must have known many things about this. But public health dentistry is about detailing the whole topic. So when ART is being dealt in PhD, particularly, you get into depth into particulars about atraumatic restorative treatment. Now, what all will be covered in today's demo lecture. See, we will be dealing with introduction, history, definition, goals, principles of atraumatic restorative treatment, the indications proper, the contraindications, and the instruments and materials which are used. Along with that, we'll also see the principal steps which are involved in the process or procedure of atraumatic restorative treatment, sharpening of instruments, advantages and limitations, retention or the survival rates, public health significance, and conclusion. I'll be dealing with this topic, and meanwhile, if you have any doubts, you can make the points, and I'll solve all the queries right after this lecture ends. So, I'll be beginning with the introduction. So, before I begin with the introduction, I would like to tell you all that atraumatic restorative treatment particularly comes under the preventive dentistry. If you will see the various domains of public health dentistry, it has got 4 to 5 particular domains, and preventive dentistry is the one which deals with atraumatic restorative treatment. Now, how it is under preventive treatment? See, it's a treatment basically. So, but what makes it come under preventive treatment is what we'll understand in this lecture. So, introduction, like earlier, it was believed that caries frequently progressed beyond reversible stage. Since there was no particular treatment that was offered to caries, there was no prevention in the previous times. So it was thought that there comes a stage where caries frequently progressed beyond the reversible stage, and there was a belief that tooth loss is particularly a part of life. So there was a need to develop this new approach in oral care, and this was reinforced by World Health Organization. Then this brief illustration will show you how all caries happen, like under a particular amount of time in an environment in the presence of host due to a particular agent, we have these carious lesions covering up. Apart from that, the modern approach, see, drilling and filling, this was the previous approach, but minimal intervention dentistry deals with particularly removing that area which is carious and conserving as much as of tooth structure possible. Now, this minimal intervention is a particular branch of dentistry. In this minimal intervention dentistry, we have atraumatic restorative treatment. So this particular branch, this particular topic that I am dealing with, by now it should be clear that it comes under preventive dentistry, and it is a part of minimal intervention dentistry. Minimal intervention dentistry, as the term itself says, minimal means very less. Intervention means any action. So minimal intervention dentistry comes under that branch which needs very less amount of interference or intervention, and hence ARTs are also part of it. Then this particular treatment was developed in Tanzania in the mid 1980s, and it was a part of community based primary oral health program. See, all these points, they are very much important, because when you write any answer, when you remember any fact about any particular treatment, where it was developed and when it was developed plays a major role. And this particular atraumatic restorative treatment was a major breakthrough when it comes to dental caries treatment. It was a major breakthrough. So hence it's very important to memorize even the dates and even the place where it was developed. Then, what was the basis of this particular treatment? See, first point, as I have already told, that it is based on minimal intervention. Then, maximal prevention. Only these two ideologies are there, that there is minimal intervention and there is maximal prevention. Then, viable approach by WHO for treatment of dental caries. This was decided by World Health Organization itself that this particular approach is a viable approach. Now, manual excavation is done in atraumatic restorative treatment. It eliminates the need of giving local anesthesia. It eliminates the need of expensive instruments, as only hand instruments are involved. It restores glass cavity with glass ionomer. Glass ionomer, as we all know, it's an adhesive material that bonds to the tooth structure and releases fluoride as it stimulates remineralization. Then it's non-invasive technique, and it's highly acceptable to the patient. History, as I've said, particularly if we deal with year-wise history, this particular point has been mentioned before, that it came up in mid 1980s in Tanzania, and it was a community-based primary health program at that time. Then, in the year 1986, there was a pilot study was done, and this result of pilot study was confronted to Tanzanian Dental Association, and further minimal intervention ART was born. Then in the year 1988, what happened that WHO Collaborating Center for Oral Health Services Research at University of Netherlands, they proposed a model for the refugees and displaced persons, that for them it's not possible that they get the accessibility of a particular dental chair or the rotary hand instruments. So particularly for them, refugees and displaced persons, this was proposed that they get treated for their caries by atraumatic restorative treatment. Then further in 1991, A community field trial was done, and there was a comparison done between ART and mobile conventional equipment cavity preparations, that is our amalgam. So then in the year 1992, regarding ART, this evaluation was done of this comparison, and the children who were treated with atraumatic restorative treatment, they were happily participating as compared to the rotary handpieces treated ones. Then in the year 1994, in 7th April, this was official adopted by WHO. So the major landmark and the major timeline that you need to memorize is that it came up in mid 1980s in Tanzania, and then it was officially adopted by WHO in the year 1994. Then in the year 1996, ART was used across 25 countries. Then in the year 2002, it was adopted as one of the examples of minimal invasive dentistry by Federation Dentaire of International. Then by whom it was developed by, who particularly gave a traumatic restorative treatment. We have Dr. Joe Franken who gave this particular treatment. And then the definition of ART. See, we all know that it makes use of hand instruments, and we all know that it has got GIC implemented in it. But what is the main definition? That particular frame can be divided into three sections. So first is atraumatic restorative treatment. It can be defined as a dental caries treatment procedure, and it involves removal of soft and demineralized tooth tissue by using hand instruments alone, and followed by the restoration of tooth with an adhesive restorative material, routinely glass ionomer. Then, what are the goals of this particular treatment? The first goal was to preserve the tooth structure. That's why we avoided using particularly our hand pieces. And the second goal was to reduce the infection. And the third goal was to avoid discomfort. What are the principles based of this? There are two principles. First is there was removing the carious lesions using just the hand instruments, and second was restoring the cavity with the restorative material that sticks to the tooth. And GIC was found to be the most apt material for restoring the cavity, which is prepared by this procedure. Then, why do we use hand instruments in particular? There are many reasons, and many of them are listed here also. First of all, it makes the restorative care accessible for all population groups, because for every population group you cannot carry a hand piece, and you cannot carry a particular dental chair and the various accessibilities in the remote areas. So with the help of this hand instruments, it was made possible. It has got a biological approach. Then it causes less trauma to the teeth, and no cost is involved, as hand instruments as compared to the hand pieces has got less cost involved. Then limitation of pain is there. There's no need of local anesthesia, and it reduces psychological trauma to the patients. And it has got simplified infection control, because hand instruments can be easily sterilized, or they can be easily we can with the help of a cotton or a methylated alcohol spirit, we can easily sterilize them and reuse them. Then what were the reasons for using GIC as a restorative material? We know many, and some of them are: first of all, it sticks to the teeth. Secondly, it has got no need to cut sound tooth tissue to prepare cavity, because the sticking property of this GIC makes it all stick to that particular cavity. Fluoride is released to prevent an arrest caries. So along with the treatment, it is also fulfilling the procedure of prevention. So that's why it comes under this ART, comes under preventive dentistry, because the restorative material that we are using here, it particularly treats those caries, and it further prevents those caries, because GIC has got fluoride release. When we apply GIC, it releases fluoride, and as a result of this, it prevents and arrests caries further. Then there are no inflammation in tissues due to glass ionomer cements, and hence it provides both preventive as well as curative treatment procedure. Then the indications where all we can use atraumatic restorative treatment. like in the small and shallow cavities. Then, in very young children, those who are not previously exposed to dentistry, and to give them an exposure which can be convenient to them, we can use atraumatic restorative treatment. Then, in the patients with extreme fear and extreme anxiety, it is safe to use ART. Those who are homebounded elderly and those who are living in nursing homes. For all of them, ART is better option. And for mentally, physically handicapped patients, and for those in high risk caries cases as an intermediate treatment to stabilize it. Then here's a diagram in which you can see enamel caries and dentine caries. So in both these cases, we can use atraumatic restorative treatment. Further, contraindications. Contraindications, like for instance, if there is swelling or fistula, we should avoid using this treatment. And in the cases where there is exposed pulp, in the cases where there is chronic inflammation of the pulp, wherever carious cavity is inaccessible to hand instruments, there we cannot give this treatment. Then, this is a diagram in which you can see that pulp is involved and abscess is there. So, automatically, it's very much evident that ART is not going to treat this particular case. We should avoid using this. And this is a contraindication. Now, what are the instruments and materials used in ART? They are very easy to go with. So, I'll just name them and I'll just tell you their purpose. First of all, we have mouth mirror. In mouth mirror, we all know it has got this particular function that it reflects light, indirect view is there, and it retracts cheek or tongue. Another instrument is Explorer. Explorer helps us in identify soft caries dentine, and the soft caries dentine can be removed. Dentine has got particularly two types when it comes to treating such cases. We have got soft caries dentine and the leathery dentine. We should try our best to remove the soft caries dentine, but we should try our best to preserve as much of leathery dentine as much as possible. Then the third instrument is tweezer. Tweezer can be used to carry cotton, wool, rolls, pellets, wedges, and articulating paper. Then the next we have spoon excavator. Spoon excavator can be used for removing soft carious lesions. To identify soft carious lesions, we have explorer, but to remove it, we have spoon excavator. And there are two types of spoon excavator. One is small, another one is medium. Small one is 1 mm in diameter and medium one is 1.5 mm in diameter. Then we have the dental hatchet particularly, which is used for widening the entrance to the cavity. Then we have applier or carver. As the name says, it is used for inserting mixed GIC into cavity and it is used to remove excess restorative material. Then we have the mixing pad and spatula. As the name says, we all know it is used for mixing GIC. Then a very important component of it is this operating light. And this operating light can be of two types. We can have the natural light or artificial light. Though artificial is more reliable and constant and can be focused on a particular spot, and portable light source is recommended in cases of ART because ART is done at such remote places that we can have a portable light source in spite of having the whole artificial operating light setup. Then we have another essential category of cotton wool rolls and cotton wool pellets. We all know cotton wool rolls are there for absorbing the saliva. When we are performing the isolation procedure, we make the use of cotton wool rolls, and cotton wool pellets are used for cleaning the cavities. Then petroleum jelly. Petroleum jelly has got a very strong link with the GIC because it keeps moisture away from GIC and it prevents sticking of gloves to the GIC. Then plastic strip. When we do multiple restorations in cases of atraumatic restorative treatment, we make use of plastic strip. Then there is contouring of proximal surfaces of multiple surface restoration due to plastic strip. Then wedges we have for placing these plastic strips, we have wedges. Then GIC. GIC is a very essential material. It is supplied as a powder and liquid, and which type? Particularly, we make use of type 8 for atraumatic restorative treatment. Even in the classification of GIC fuel C, type 8 is referred to as the atraumatic restorative treatment GIC. Then we have other. some other particular materials and armamentarium which is required. We have examination gloves, mouth mask, operation bed via headrest extension tool, methylated alcohol as a spirit, pressure cooker, instrument forceps. Then we have soap and towel, sheet of textile, sharpening stones. Then the principal steps which are involved in the procedure of atraumatic restorative treatment. We have isolation, then preparing the cavity, then cleaning the prepared cavity, then mixing of restorative material, and then restoring the cavity. First of all, isolation. This is a very important aspect. And cotton wool rolls that I have shown earlier, they are quite effective in absorbing the saliva. In this diagram, you can see that in lower jaw, how isolation is done, and in the upper jaw, how cotton rolls with the help of cotton wool rolls, we are having isolation. Then, second step is the preparing the cavity. We have to remove plaque with a wet cotton wool palette, and we have to dry the surface with a dry palette. Then further, we have to remove the soft caries by circular scooping movements with the help of an excavator as shown in the first diagram. And in the second diagram, you can see there is a dental hatchet. With the help of that, we can overhanging enamel is removed with the help of dental hatchet. And we have to place the instrument at the edge of enamel and fracture of the small pieces. Only then it's going to give the most efficiency. Then preparing the cavity only, excavation is very easy to do when the teeth is dry. So therefore replace the wet cotton rolls that we were using with dry ones for use. Then after all caries is removed from cavity, it is cleaned with wet cotton wool. Then next step is cleaning the prepared cavity. First step was isolation. Second step was making it all. Then third is the cleaning the prepared cavity. Second was preparing the cavity. To improve chemical bonding of GIC, cavity walls must be very clean, because if the cavity walls are not going to be clean, a restorative material cannot be inserted, and if it is inserted, it will come out very easily. So the prepared cavity has to be very clean. A chemical solvent can be used as what wet cotton rolls are not much effective. Dentine conditioner can be used, and liquid supplied with glass ionomer itself can be used. These two materials can be used for cleaning the cavity that we have prepared with the help of hand instruments, particularly dental hatchet and spoon excavator. Then this is a diagram in which you can see application of a dentine conditioner. This is the cavity that was prepared by hand instruments, and then we are applying the dentine conditioner. Then next step is the mixing the restorative material. First step was isolation, then we were preparing the cavity, then we cleaned that cavity, and now we are mixing the restorative material. So the treatment material particularly is GIC titrate, and it contains both powder and liquid. And powder has got this major component of silicon oxide, aluminium oxide, and calcium fluoride. You need to memorize this. And liquid has got a major component of polyacrylic acid. Then clinical characteristics of GIC, if we talk about, it bonds chemically to enamel and dentine. It has a good cavity seal because of this reason. There is slow release of fluoride, hence it is anti-cariogenic, and it prevents dental caries around restorations. It is non-irritating to both pulp and gingiva. And after 24 hours, when completely set, it is completely non-irritating and biocompatible. And adverse reactions don't occur anymore when it is completely set. Then this is a diagram in which you can see the mixing of restorative material is done with the help of powder and liquid. One drop of it's taken in the ratio of 2:1, and after this we get to mix this with the help of our spatula, and we have to mix it proportionately, and the duration for the whole mixing, as we all know, is 20 to 30 seconds itself. Type 8 GIC is used. And restoring cavity insertion, next step is the restoring the cavity. Till now we are done with isolation, we are done with preparing the cavity, we are done with cleaning that particular cavity, and now mixing of the restoration material is done, and now we have to insert that material into the restored cavity. Insertion of restorative material into cavity, it must begin immediately, and make use of applier or carver, and this will avoid the air trapping, and 30 to 40 seconds duration is acceptable. In mixing, 20 to 30 seconds duration was acceptable, and in restorating, 30 to 40 seconds is acceptable. Then we have restoring the cavity. We have a press finger technique. Like, we have to roll the petroleum jelly on the gloved index finger and then on the restorative material. With this, a pressure can be created, and the excess material is removed with a carver afterwards. Then cover the restoration with a new layer of petroleum jelly. Patient should not eat for at least half an hour so that the GIC can particularly set. Now the carious cavity, they are divided into two types. Either can be one surface or multiple surface. If we talk about one surface, we have these examples like pit and fissure on occlusal surfaces of premolars and molars, and the image is also illustrated. Pits on the lingual surfaces of upper incisors, buccal groove of lower molars, buccal surfaces just above the gingiva, and proximal surfaces of anterior teeth. If we talk about multi-surface lesions, we have occlusal and proximal surfaces of a premolar and molar, occlusal and lingual surfaces of a molar, and proximal and buccal surfaces of an anterior tooth. Then sharpening the dental instruments. Since we are using just hand instruments, it's very necessary that we sharp those instruments. And if we won't sharp them, they won't be that much efficient in giving that treatment or restoration a better touch. So hand instruments used for cutting hard tissues, example excavator, dental hatchet or carver, they must be very sharp. And the blunt instruments, they require excessive force to cut enamel and dentine, so sharpness can be checked on the thumbnail. This is an image in which you will see the sharpening which is done, and first one shows the correct and incorrect position for the sharpening of a dental hatchet, and second one shows the correct and incorrect position of sharpening of a spoon excavator. So keeping these positions for hand instruments, we can get to assess how it can be sharpened, and sharpening is a very important protocol in the treatment procedure of ART. Hygiene and control of cross infection, that is achieved by always wearing gloves. We should always clean and disinfect our working place. Then it can also be done by cotton gauzes impregnated with methyl spirit or alcohol. Then in a clinic, autoclave or pressure cooker is used for sterilization of instruments, and particularly some more measures are there to avoid risk of infections such as hepatitis and HIV. We should follow these protocols. Then next we have operator's work posture. The one who is treating the case of this particular treatment has to sit firmly with a straight back. The thighs should be parallel to the floor and both feet should be flat on the floor as shown in this diagram. Then assistance. As we all know that oral care is best provided by a team consisting of an operator and an assistant, but however, assistance is not always possible. So, if present, assistant works at the left side of a right-handed operator, and if the operator is left-handed, the assistant will do his work at the right hand. It's opposite. And patient's position, if we talk about, patient should lie on a flat surface that will provide safe and secure body, and there should be a proper support for the patient so that he or she is at her comfort zone. Patient should be comfortable as there can be lengthy operating time periods too. Then we have patient's head. How can we position patient's head while we are treating him or her? Backward tilt lifting the chin is done to have an access to the upper teeth, and forward tilt dropping the chin is done to have access to the lower teeth. Then we have another range of positions, and the most commonly used ones. The range of positions can be 10 to 1 o'clock, but the most commonly used ones are direct rear, that is 12 o'clock, and right rear, that is 10 o'clock. Then we have monitoring restorations and the sealants that we have given. First of all, no restoration or sealants last forever. Even this one have got some particular duration. Some restorations or sealants can last for years and some may fail earlier. Ask the patients about the pain and the overall satisfaction within a period of 4 weeks after being treated. That is the duration that is kept for this particular treatment. After we have administered the patient with this particular treatment, after 4 weeks, we should ask that patient about the pain and overall satisfaction he or she has got regarding the treatment. First clinical evaluation should be done after half an year, and further it depends on annual or biannual basis. It depends on many reasons. Then failed or defective restorations, if we talk about, we should examine carefully for the caries in those defective restorations. If the surface is hard, we should leave it alone, and if the surface is carious, we can make a small restoration. And there is a category of completely unacceptable restoration cases. Like, for instance, the restoration is completely missing. In that case, we have to treat it all over again. A large part of it got broken away, then also we will have to treat it all over again. If the restoration is fractured, that also comes under the category of unacceptable restoration cases. Then we have much of restoration material is worn away. In that case too, we have to consider it as unacceptable if the caries has developed on the restoration margin or elsewhere on the tooth surface. Then we have next, whatever be the reason, clean the cavity completely, apply dentine conditioner, refill the cavity according to description. Then this is a pictorial representation of, in the first one you can see there is active caries. Then after the caries was removed with the help of hand instruments, glass ionomer restoration was done, and after 1 month healing was there because GIC releases fluoride.
That happens, no issues.
Yeah, so going ahead with the advantages, we had these that in the young patients and extremely uncooperative patients, we can actually make use of this treatment. We can give this treatment. Then moving ahead, it can help to maintain a natural tooth eruption pattern because it doesn't interrupts with that eruption pattern, and it avoids disturbances in the positioning of the permanent teeth. And the benefits, if we overall talk about, we have got prevention as well as remineralization, and it reduces patient anxiety and it provides a better oral health. Further, if we talk about the limitations, we all are now, by now familiar with the advantages of ART. If we talk about limitations, there is no guarantee for long-term survival rates of ART. Then the use is restricted to very small and medium-sized one-surface lesions. Then hand mixing might produce an improper mix depending upon individuals, and possibility of hand fatigue might be there because as long as we use the hand instruments, so the probability increases of the hand fatigue. Some important considerations that we'll have to keep in mind is that emphasis should be made on preventive measures, and along with that, emphasis should also be made on removal of plaque, counseling on proper diet, application of fluorides, application of antimicrobial agents, and application of sealants. Like, in short, administering someone with just ART is not a complete treatment. We have to look into all aspects and we have to emphasize on each and every measure, on each and every aspects for an overall well-being. Now, the survival or retention of ART, we talk about, it has got single surface restorations are more successful as compared to the multiple surface restorations. Then the high viscosity GIC retains longer than the medium viscosity. So while we are mixing that GIC, we have to keep this in mind. Then it depends upon material use, training of operator, and the extent of caries. Then public health significance, if we talk about, because ART as a topic is there in our public health dentistry, we talk about that. It has got, like, in 21st century, dentistry surely belongs to the provincial paradigm. Like minimal intervention approach accompanies up-to-date caries diagnosis and risk assessment before arriving at the treatment decision. That means prevention should be there and prevention should be more prevalent as compared to treating that particular caries. Then the minimal intervention philosophy could be fruitfully incorporated into contemporary preventive and public health dentistry. If we talk about more public health significance, like it's just the time for the changes in principles of operative dentistry, the disease should be treated first, the surgical approach should be undertaken only as a last resort, and efforts should be made to preserve the maximum amount of sound tooth structure. Then we should be engaged in treating caries and not the cavity anymore. Then conclusion, minimal invasive approach to prevent dental caries lesion and stop its further progression. It basically consists of two components, sealing of the caries prone pits and fissure with the help of ART sealants and restoration of cavitated dental lesions with the help of sealant restorations or ART restorations. Then ART is sometimes criticized as only a restorative treatment, but now you all can very much relate to the fact that it is not just a restorative treatment but a palliative treatment too. Then it can be performed by not only dentists but dental therapists too. Then, earlier the purpose was to bring healthcare to rural areas where urban trained doctors would not settle, and it increases the chance for better oral health in underdeserved communities in both developed and developing countries. Then, this was all about this atraumatic restorative treatment. Any questions or any doubts, you can ask me now. Any one of you. Any one of you having any doubts in ART, or is it all clear? Because it is comparatively a topic which is of very much relevance to all of us. Anyone having any doubts?
Okay, I guess instead of asking them the doubts, we'll ask them whether was it clear or not. So in the chat box, you all just can give a thumbs up or type anything on the favor of the explanation and the lecture what ma'am gave. If you have any queries, you can just post it on the group also. Can you guys hear me? Dr. Raj, Surbi, Arshia. Yes, Arshia is saying it was clear. Yes. We have a lot more on this platform, right? We have 8 to 9 people. Priya, Rasika, Surbi, everyone. We want a response from you guys. That is when
Yeah,
we
yeah,
know.
actually.
Yeah, Rasika also says it was clear. Okay, so most of the students feel it was clear. So now I have something special for all those who have waited till the last moment of this lecture, right? Because this was a demo lecture, and after this, the students can opt for registering for this course for public health dentistry, right? So there is a special offer for all the students who have shown their
And also, I
interest.
want to ask, like, was it informative? Like, as you read in Shobin Peter, was it a bit different, like a bit more interesting, a bit more informative? Is the purpose of these classes to make your topics more understandable? Yeah.
Yeah, it was a very nice session from Dr. Raj Kishore Singh. Thank you so much. He's saying more informative by Amrita. Yes, so yes, I would also accept the fact that it was very much informative and it added few points into my information what I had about ART, that is a traumatic restorative treatment. Topic was covered and it was a very nice lecture from your side. Okay, so just a request to all the candidates from my side, can you just on your cameras if you don't mind? I'm not your faculty or staff, right? I'm someone who is of your age or a little bit more than your age. So if you guys feel free to on your cameras, you can go for it. Otherwise, it's fine, not in compulsion. But yeah, it would be great if you on your cameras and would have a more interactive session. So all the candidates who just showed their interest in joining the demo class, I'm having a special offer for you guys. The course price will be revised for half an hour. The the price will be reduced to 1200 rupees for the public health dentistry instead of 1349. And this that I have posted the payment link in the chat box, if you guys can see, right? So you can, what you guys can just do is you can go to this payment link and register yourself in this half an hour 45 minutes frame. Mostly we can wait till 8:30, I guess. Yes, so till 8:30 we'll have this link activated for all the candidates who had attended the demo class, right? So Arshia, Amrita, Rajkishore, and the rest of the people can go through this link, or you can just copy the link and save it for yourself. You can talk to your parents, consult with them, and then go with the registration. But just make sure your guys are doing it by 8:30, right? Because the link will automatically get deactivated. So if I want to activate for you also, I cannot do that. It's not in my hands. That is, everything is computer generated, right? So you guys just can save the link, decide, go through the topic once again, just recollect what ma'am explained, and then decide what you want, right? Okay, so this was, I guess, end of the demo class, and the recording session also will be shared on the group. So for those candidates who wants to go through this lecture again and reevaluate whether they have to join or not, they can do that also. But then the price won't remain the same. Okay, so the prices will be 1200 right now, and then again it's gonna be same, that is 1349. So I guess this is it for tonight, and any more discussions you guys can ping me on the WhatsApp chat or on the group, or you can call me as well. You have my contact number everywhere, right? So thank you so much, Arshia, and all the candidates who joined this demo class and showed interest in our venture. Thank you so much, and see you soon for further demo classes, and hope we get to see you on the platform of Masterclass 1.0 for the next 2.5 months. Okay, thank you, Aisha. See you in the next demo class. Bye bye. Take care.